Good day and welcome to NCM 109, Care of Mother and Child at Risk or with Problems, Acute and Chronic. This is Group 4F and we will be talking about the last set of antenatal complications. To give you an overview of the things that we will be discussing, we have here the contents. First, drug abuse. Second, urinary tract infection. Third, sexually transmitted disease. Fourth, torch. Fifth, multiple pregnancy. And sixth, hydramnios. For every antenatal complication, we will be discussing the following. First, its definition or description. Second, its etiology or cause. Third is the types. Fourth is the signs and symptoms. And fifth is the management in terms of nursing, medical, pharmacologic, surgical. Sixth is the related pictures or videos. And seventh is the nursing care plan. Before we begin the discussion, let us know the members of the group. TAGHOY Monicca, Zacht Abraham, TORRED Jewel, Tumulak Nicole, ULEP Benedict, Elaiza May, VILLANEUVA Cassandra Maureen, YBANEZ Brian Anrou, Marie Yvonne, ZALDUMBIDE AINHOA, UBAS JHORIZA, VILLACERAN Roby and VILLAMOR Henrelyn. Let us now begin our discussion on our first antenatal complication. Good day, viewer. My name is Zacht Abraham and I will be talking about drug abuse. Drug abuse is defined as the maladaptive or excessive use of drugs for non-medical purposes despite the possible problems that may arise. This can start with experimental and/or voluntary use of a recreational drug in situations, and for some people, it is being used more frequently. For others, particularly with opioids, drug addiction begins with people who are exposed to prescribed medications or receiving medications from someone who has been prescribed the medication. From here, we will be discussing the types. First, alcohol. Chronic alcohol use during pregnancy may cause miscarriage, stillbirth, and a range of lifelong physical, behavioral, and intellectual disabilities, also known as fetal alcohol spectrum disorders or FASDs. Second, opioids or narcotics. Opioid dependence, addiction, and overdose, especially during pregnancy, can cause problems for both the mother and the baby, which may include neonatal abstinence syndrome, neural tube defects, congenital heart defects, miscarriage, preterm labor, and low birth weight. Third, cocaine and methamphetamine. Using these may cause serious problems for the baby before and after birth, such as placental abruption, premature birth, low birth weight, miscarriage, neonatal abstinence syndrome, and other long-term health problems. Fourth, marijuana. This can also make a pregnant mother dizzy and have altered judgment, putting them at risk of falls or other injury, as well as damage to the lungs and can cause breathing problems. Fifth, nicotine. According to the CDC, mothers who smoke early in their pregnancy are more likely to have placenta problems and deliver babies that have several different heart defects, low birth weight, and are premature. Sixth, phencyclidine. It is a frequently abused drug due to its euphoric effect and also has been shown to cross the placenta and may cause harmful effects in the fetus. Now we have understood its definition and its types. What are the common signs and symptoms of drug abuse, specifically for the mother? First is the physical symptoms. The mother may have bloodshot eyes, change in complexions, poor personal hygiene, interrupted sleep patterns, and losing weight quickly. Second is the psychological symptoms. The mother may experience low self-esteem, mood swings and irritability, and even depression and anxiety. For signs and symptoms on the baby, we have, first, drug withdrawal on newborn, blotchy skin coloring, seizures, sleep problems, excessive or high-pitched crying, abnormal sucking reflex, and rapid breathing. For the long-term and possibly fatal effects, we have premature birth, a small head circumference, birth defects, low birth weight, sudden infant death syndrome or SIDS. We have now reached to the point where we must understand how to manage drug abuse. First is nursing management. We must assess the client's history. Ask the client his or her history, because clients who have a parent or other family members who are addicted to drugs or alcohol may describe a chaotic home life. However, this is not always the case. Second, assess the client's thought processes. Clients are inclined to minimize their substance usage, blame others for their difficulties, and rationalize their conduct throughout the evaluation of the thinking process and content. Assess the client's sensorium intellectual process. During the assessment, unless the client is suffering from withdrawal symptoms, they should be normally focused and aware. Next is to assess the client's general appearance and motor behavior. A comprehensive assessment of appearance and behavior typically reveals that appearance and speech of the client is normal. Next, we need to assess the client's self-concept. Clients tend to have poor self-esteem, which they may express openly or cover up through dramatic behavior. Other things that a nurse can do to manage this are to closely monitor maternal and fetal well-being, explain the benefits of abstinence of substance abuse during pregnancy, discuss possible effects of drugs on the newborn, provide support to the client and family, provide support for the decision to stop substance abuse, provide education opportunity, pamphlets, consultation with appropriate persons. Second is the management of drug abuse through medical methods. First is withdrawal. Through withdrawal, detoxification can occur throughout the body. Although this is usually accompanied by further treatments after withdrawal, since there is a higher chance that users will go back to their usual habit and drug use. Second, relapse prevention. Medication can help patients reestablish normal brain function and reduce cravings. Opioids such as heroin, prescription pain medicines, tobacco like nicotine, and alcohol addictions can all be treated with medications. Other drugs to treat stimulants such as cocaine and methamphetamine and cannabis marijuana addiction are being developed by scientists. People who use numerous drugs, which is fairly frequent, require medical attention for all of their drugs. Third is the pharmacologic approach in the management of drug abuse. First is the use of benzodiazepines. Alcohol withdrawal is usually managed with a benzodiazepine anxiolytic agent, which is used to suppress the symptoms of abstinence. Second is disulfiram. Disulfiram or antabuse may be prescribed to help deter clients from drinking. Third is acamprosate. This is to help reduce cravings for alcohol and decrease the physical and emotional discomfort that occurs, especially in the first few months of recovery. Fourth is methadone. Methadone is used as a substitute for heroin in some maintenance programs. Fifth is levomethadil. Levomethadil is a narcotic analgesic whose only purpose is the treatment of opiate dependence. And last is naltrexone. Naltrexone is an opioid antagonist often used to treat an overdose. It can also be used to treat alcohol abuse. And the last method for managing drug abuse is through surgical methods. One example is deep brain stimulation, or DBS. This is a powerful tool for modulating dysregulated networks that has demonstrated successful application and been granted approval for the treatment of several neurological disorders. This has also been considered for the treatment of substance addiction. Here we have some relevant pictures and videos. The first photo can show us that drugs have unwanted signs and symptoms to our bodies. And second is that drugs can come in many forms. It can be injected, swallowed, drunk, or inhaled. And here, our third photo is the deep brain stimulation. And in here, we will now be presenting a video related to drug abuse.
I will now be presenting our nursing care plan for drug abuse. We have come up with a physiological problem, which is inadequate dietary consumption. For our objective cues, we have small body frame, weak looking, has dry skin, and below maternal recommended weight. For our subjective cues, the client reported that she has altered taste sensation. The client also verbalizes that she has no appetite. Based on these cues, we have come up with a nursing diagnosis, which is imbalanced nutrition, lessened body requirements related to substance abuse. So for our scientific basis, pregnancy alcohol usage is typically coupled with poor nutrition, which might significantly worsen brain damage. So if pregnant woman does not frequently consume adequate levels of micronutrients like choline, folate, vitamin B12, iron, and vitamin A, they may be particularly crucial in FASD. In addition to that, alcohol and drug abuse can impede nutrient absorption, reduce the quality and amount of proper nutrient and energy intake, resulting in malnutrition, particularly of micronutrients, which I have mentioned a while ago. So when the nutritional status of the mother is damaged by alcohol and other drugs of abuse, the availability of vital nutrients for the baby is reduced, which can result in fetal abnormalities such as intrauterine growth restriction or IUGR or fetal alcohol spectrum disorder or FASD. So for our general objective, after 2 days of holistic nursing care, the client will be able to recognize the relationship of substance abuse to the current situation. After a day of nursing interventions, the client will verbalize understanding of effects of substance dependence and insufficient dietary intake. Next, the client will demonstrate behaviors and lifestyle changes to regain or maintain an appropriate weight for pregnancy. And lastly, the client will demonstrate progressive weight gain towards goal with normalization of laboratory values and absence of signs of malnutrition. To achieve the objectives of our nursing care plan, we have come up with the nursing interventions, which are measures to help improve the client's nutritional intake. First, assess the client's anthropometric measurements. This helps measure subcutaneous fat and muscle mass to help in planning dietary needs. Next, educate the client about the advantages and disadvantages of well-balanced nutritious intake. This is to help the client understand the pros and cons of having a well-balanced diet, as well as guiding them to make informed choices about the future. Next, encourage the client to have a food diary. This will help determine the client's nutritional strengths, needs, and insufficiencies. So a food diary is a very good mode of information where you can get the preferences of the client when it comes to food and even their allergies. Number 4, monitor the client's laboratory results as indicated. The data that will be gathered will be used to determine the patient's overall health and well-being. Number 5, monitor the client's nutritional intake as recommended by the dietitian. This will help determine and measure the amount of progress made for the nutrition intervention and to check whether the expected goals are being met. And lastly, we can collaborate with a nutritionist to obtain an individualized nutritional plan. Collaborating with a nutritionist is very helpful in improving and recovering by creating an individualized meal plan that is aimed to help the client get the proper nutrition they need. That concludes our report for the drug abuse. Thank you.
Hello, this is Nicole Tumulak, and I will be discussing the urinary tract infection, its definition, etiology or cause, and the types. So definition, urinary tract infection or UTI is an infection in any part of the urinary system, namely the kidneys, bladder, ureters, and urethra. This infection commonly happens when bacteria enter through the rectum or urethra and infect the urinary tract. Females are at higher risk of this infection since their urethra is shorter and closer to the rectum. Now for the etiology or the cause of UTI, UTI are caused by microorganisms, usually bacteria, that enter the urethra and bladder, causing inflammation and infection. Though UTI most commonly happens in the urethra and bladder, the bacteria can also travel up to the ureters and infect the kidneys. Now, the urinary tract infection may involve different sections of the urinary tract, including the following. So we have urethritis. This is an infection of the urethra, the hollow tube that drains urine from the bladder to the outside of the body. We also have cystitis, a bacterial infection in the bladder that often has moved up from the urethra. And then we also have pyelonephritis, an infection of the kidneys that is usually a result of an infection that has spread up the tract or from an obstruction in the urinary tract. An obstruction in the urinary tract causes urine to backflow into the ureters and kidneys. We also have vaginitis. It is an inflammation of the vagina that can result in discharge, itching, and the pain. Bacteriuria is the presence of bacteria in the urine, and we also have asymptomatic bacteriuria, which is the absence of symptoms but there is the presence of bacteria in the urine, or what we call the silent infection.
Good day everyone, my name is TORRED and I'll be continuing the report on UTI. So now here we have signs and symptoms for us to know whether a person has UTI. For signs, there is suprapubic pain. This is basically pain located in the lower abdomen. There is blood in the urine, also known as hematuria, and uterine contractions or activity. This is due to the infection causing smooth muscle irritability. For symptoms, there is pain or burning sensation when urinating, also known as dysuria, frequent urination, constant need to urinate even when bladder is empty. There is also fever, chills, nausea, and vomiting. Moving on to the nursing management. Here, the nursing care of the patient with UTI focuses on treating the underlying infection and preventing its recurrence. So first we have to undergo a nursing assessment. This is where we'll be obtaining a history of signs and symptoms related to UTI from the patient with a suspected UTI. 1. We have to assess the changes in urinary pattern, such as frequency, urgency, or hesitancy. Second is to assess the patient's knowledge about antimicrobials and preventive healthcare measures. And third, we are to assess the characteristics of the patient's urine, such as the color, concentration, odor, volume, and cloudiness of the urine. For medical management, first we can obtain urine sample. So the doctor may ask for a urine sample for lab analysis to look for white blood cells, red blood cells, or bacteria. For us to avoid potential contamination of the sample, the client may be instructed to first wipe their genitalia with an antiseptic pad and to collect the urine midstream. Second is lab analysis of the urine. So this will help tell the doctor what bacteria is causing the infection and what medications will be the most effective at treating them. Third is creating images of the patient's urinary tract. So if the patient has frequent infections, this may be caused by an abnormality in the patient's urinary tract. You may have an ultrasound, a CT scan, or an MRI for better visualization. Fourth is to use scope to see inside the bladder from the urethra. So if you have recurrent UTIs, your doctor may perform a cystoscopy using a long, thin tube with a lens, also called cystoscope, to see inside your urethra and bladder. For the therapeutic management of uncomplicated bacterial urinary tract infections, this is based on short-term courses of oral antibiotics. So the preferred drugs are the following: nitrofurantoin, dermethoprim sulfamethoxazole, fosfomycin trametamol, fluoroquinolones, and B-lactam agents. The choice of agent for treating uncomplicated UTIs should be based on the pharmacokinetic characteristics of the molecule so that the clinical benefit of these drugs is optimized and the risk of antibacterial resistance is also minimized. And lastly, surgical management. So surgery remains a very important and viable solution. Here we are to remove identified sources, treat the obstruction, and improve urinary drainage, which are all goals of surgical management. Surgical options for UTI management can range from minimally invasive procedures, such as endoscopic surgery, wherein the surgeon inserts a thin, flexible tube with a video camera through a small incision, or percutaneous surgery, which is done via needle puncture of the skin. Two more invasive procedures such as laparoscopic surgery, also known as keyhole surgery, which uses several incisions to access the abdomen and insert a laparoscope, or an open approach surgery. So now, here we have some relevant pictures and videos for you guys to have a better grasp on what UTI in pregnancy is. Okay, so here is an example of a nursing care plan for UTI, wherein we'll be focusing on the physiological problem, which is acute pain. For subjective cues, the client has verbalized, sakit inig pangihi nako, which indicates he or she is feeling pain while urinating. For subjective cues, the client is showing facial grimace, restlessness, and a pain scale of 4/10. For our nursing diagnosis, we have impaired urinary elimination related to dysuria and frequent urination as evidenced by irritated and inflamed urethra. So, the urethra becoming inflamed and irritated usually indicates urethritis, which typically causes pain while urinating and an increased urge to urinate, which are some of the factors that impact urinary elimination and places the client at risk for impaired elimination. This often signifies an infection in the urinary tract by bacteria.
Hello, this is Nicole Tumulak again, and I will be continuing to discuss the nursing care plan of the urinary tract infection. So we have first the objectives of care. So after 2 days of holistic nursing care, the client will experience normal and painless urination. Specific objectives, we have after 1 day of nursing intervention, the client will identify causing factors of the STD, demonstrate behaviors and actions to reduce the infection. Now for the nursing interventions and its rationale, under independent, we have assess the client's elimination. This is to provide an overview of the severity of the condition. Second, limit the use of indwelling catheters to manage incontinence. Frequent usage of indwelling catheters poses a higher risk of catheter-related UTI as bacteria viruses accumulate on the material. Third, encourage client to drink cranberry juice. Cranberry juice could reach the urinary tract and prevent bacterial adhesion within 8 hours. Fourth, encourage the client to void frequently. Frequent voiding every 2 to 3 hours to completely empty the bladder is encouraged to prevent bladder distension, lower bacterial urine counts, reduce stasis of the urine, and prevent reinfection. Fifth is use non-pharmacological techniques to manage pain. So, alternative therapies such as relaxation, massage, guided imagery, or distraction may decrease pain and provide comfort. Now, under dependent, we have monitor laboratory and diagnostic studies as indicated. Lab results will indicate if there is a change to the state of the problem. 2 is administer analgesics or antispasmodics as indicated. Antispasmodics and analgesic agents are useful in relieving bladder irritability, spasm, and pain. Third and the last, administer antibacterial agents as indicated. Trimethoprim or TMP or cephalexin are usually the first choices of antibiotics. Short course therapy using a single antibiotic or a 3-day course reduces treatment costs, increases compliance to therapy, and a lower rate of side effects.
Hi everyone, my name is Elaiza, and in this portion we will start to discuss another topic which is focused on sexually transmitted diseases, or is what we commonly known as STDs. So by its definition, STDs, or also called as sexually transmitted infections, STIs, these are infections that are passed from one person to another through sexual contact. So in terms of sexual contact, might be vaginal, oral, or anal sex, the diseases or infections can be passed through in these ways. Now, where does this come from? What is its etiology or causes? STDs can be caused by either a bacteria, a virus, or a parasite. An example of diseases that is caused by a bacteria is gonorrhea, we have syphilis, and chlamydia. For viruses, we have HPV, genital herpes, and HIV. And for parasites, we have an example of Trichomonas vaginalis. And so we are done discussing its definition and its causes. Now, let us focus on its types. First, we have the tertiary syphilis. These are the early stages of syphilis. This is a relatively uncommon infection and is considered an STI. The next one is what we call the pelvic inflammatory disease. This is a complication that is often caused by some STDs, for example, gonorrhea and chlamydia. So the scarring can make an ectopic pregnancy more likely, so there's a higher chance, and has also been linked to infertility. So the statistics around this is with around 1 in 10 people with PID is becoming infertile as a result. The next type is cancer. So certain STDs or STIs can increase a person's risk of developing several cancer types. This is, for example, HPV, or as what we call as the human papillomavirus. This is according to CDC. HPV can lead to cancer in women, cervical cancer, vaginal cancer, and vulvar cancer. The next type is what we call the genital warts. So what are genital warts? These are skin-colored or white bumps that shows up on the genitals or anus. So the statistics over this, there are over 350,000 people that is developing genital warts every year. Imagine how many people are contracting this disease. They are treatable, but sadly they are not curable, as the virus that causes them may remain. Next, we have AIDS. Of course, what does AIDS stands for? The meaning of AIDS is acquired immunodeficiency syndrome. It is the final stage of infection with HIV, and it happens when the body's immune system is badly damaged because of HIV. And take note that not everyone with HIV develops AIDS. So if you have HIV, if you have contracted the virus and you are treated at the earlier stage of the disease, then you have the higher chance that you will not be getting into severe cases, severe stages of HIV, which develops into AIDS. Okay, so the next type is HPV, or human papilloma virus. It is one of the most common STDs in the US, and there are more than 40 types of HPV, some of which can cause genital warts, cervical cancer, which may be detected during a routine screening pap smear. That is why it is very important yearly, annually, that women should take the screening. This is to prevent, or not to prevent, this is to know and to determine if you have an early stages of this virus, so we can already treat you as soon as possible. All right, let's proceed to the next types. Herpes. Herpes is commonly associated with cold sores or fever blisters or oral herpes, but there are also genital sores. Herpes can also affect the developing fetus in a pregnant woman, especially if the woman becomes infected during the first trimester. The next type, let us proceed, is syphilis. This is caused by a bacterium that is called Treponema pallidum, and it is spread through direct contact with sores that is called chancres. Early syphilis infections may begin with a painless, round, and firm single sore that is located where the bacteria entered the body. So you must be careful. You must check your body if there's any blisters, any sores, so you can inspect it. And if ever there is a complication and you don't know what to do, then you will proceed to getting a consult from the professionals. The next type is chlamydia. This is a sexually transmitted disease that is caused by a bacterium that is named Chlamydia trachomatis. That is why it is called chlamydia, from its name of the bacteria. And if this is not treated, it can lead to PID, right? Remember what PID stands for? Pelvic inflammatory disease. So in women, this will eventually damage a woman's reproductive systems and cause infertility. And so we are done with the types. Let us proceed with its signs and symptoms. Of course, what are the signs and symptoms? We have to know about it so that we can be aware if we are starting to contract bacteria, viruses, or STDs in case. First, sores or bumps on the genitals or in the oral or rectal area. The next one, painful or burning urination. Discharge from the penis. Unusual or odorous vaginal discharge. Unusual vaginal bleeding. Another one, there is pain during sex. Sore, swollen lymph nodes, particularly in the groin, but sometimes that is more widespread. Lower abdominal pain. There's a fever and a rash over the trunk, hands, or feet. So those are the signs and symptoms that we all should look out for. The next part of this would be its management and how we can manage if ever we are starting to feel unlikely that we are suspecting that we have contracted STDs. So the next part will be reported by Mr. Benedict ULEP.
Thank you, Miss Uy. So guys, I'll be continuing this report from now on. So next we have the management. So first we have the nursing management. Under nursing management, we have assessment. So first we gather data and information provided by the patient as well as from the collected data during physical examinations. Next is we have health promotion, preventive education regarding sexual exposure, encouraging safe sex to our clients, providing sufficient information regarding STDs, as well as promoting routine checkups and screenings for cervical cancer, and etc. Next, we have treatment of choice. This is the administration of parenteral penicillin for pregnants with syphilis. Those who are allergic to penicillin should be desensitized and treated with penicillin G. Skin testing or oral graded penicillin dose challenge might be helpful in identifying women at risk for acute allergic reactions. Next is adequate case finding and treatment context as well as reporting of all cases to local public authorities. So next management is we have the medical management. So in medical management, laboratory tests can identify the cause and detect co-infections you might also have. So under medical management, we have blood test. Blood tests can confirm the diagnosis of HIV or later stages of syphilis. We also have urine samples, since some STIs can be confirmed with a urine sample. Next is we have fluid samples. If you have open genital mouth sores, the doctor may get a swab of any discharge or sores. Next is we have pharmacologic management. STDs or STIs caused by bacteria or parasites can be treated with antibiotics. So these antibiotics are most often given by mouth, orally. However, sometimes they are injected or applied directly to the affected area. The treatment's complications and outcomes for viral STIs depend on the particular virus, such as HIV, genital herpes, human papillomavirus, hepatitis, or cytomegalovirus. Treatments can reduce the symptoms and the progression of most of these infections. Individuals with HIV need to take special antiretroviral drugs that control the amount of virus they carry. These drugs, called highly active antiretroviral therapy or HAART or HAART, can help people live longer, healthier lives and can prevent onward transmission of HIV to others. The antibiotics prescribed depends on what infection you have. The various antibiotics prescribed for different bacterial STDs are azithromycin, doxycycline, erythromycin for chlamydia, ceftriaxone, cefixime, ciprofloxacin, and ofloxacin for gonorrhea. Next is we have the surgical management. For patients with HPV, we have freezing with liquid nitrogen, or called cryotherapy. Freezing works by causing a blister to form around the wart. Next, we have electrocautery. This procedure uses an electrical current to burn off warts. The patient may experience some pain and swelling after the procedure. Next, we have surgical excision. The doctor might use special tools to cut off warts. Next is laser treatments. This approach, which uses an intense beam of light, can be expensive and is usually reserved for extensive and tough to treat warts. Side effects can include scarring and pain. For patients with hepatitis, in some cases, significant liver damage can occur from hepatitis infections, and a liver transplant may be needed. So here we have some relevant pictures or videos.
Oh, don't worry, you can't get infected. It's only... my allergies. Sexually transmitted diseases, or STDs, are diseases, infections, or illnesses that can be spread from a person with an STD to another through sexual contact. That includes genital-to-genital contact, which is contact with penises, scrotums, vulvas or vaginas, to any kind of sex, oral, anal, or vaginal sex. Some STDs are fairly common, so there's nothing to be embarrassed about if you ever get one. Some STDs do not cause any symptoms, so many people who have an STD do not know it and might spread it. For those who do have symptoms, they may experience soreness or swelling around the genitals, bumps, sores, or rashes on the genitals, itching, burning, or pain while urinating, and girls may get a vaginal discharge that is different from normal. If you have any of these symptoms, or if you've had unprotected sex, it's important to get tested for STDs. STD tests differ. Some are blood tests, some test urine, and still others use a swab of saliva or a discharge. Even if you use protection, it's a good idea to get tested for STDs at least once a year. You can get an STD test from your healthcare provider or at a family planning or STD clinic. Some STDs can be cured while others cannot, but their symptoms can be managed with medication. Some STDs, if left untreated, can cause serious health problems later in life. So remember, once a person becomes sexually active, it is important to use condoms and other latex barriers and to get tested for STDs regularly. Tissue for your allergies? So, till next time, don't forget to visit me at amaze.org or go to my YouTube channel to watch more. Bye!
So next, I'll be discussing the nursing care plan for STD. So for the needs, problems, or cues. So our objective cues: client has facial grimace and restlessness. For our subjective cues, client rates pain an 8 on the numerical pain scale. Client also verbalizes that she is in pain. So our nursing diagnosis is acute pain related to body response to an ineffective agent. So here we have our scientific basis. Sexually transmitted diseases are infections transmitted from an infected person to an uninfected person through sexual contact. STDs can be caused by bacteria, viruses, or parasites. Examples include gonorrhea, genital herpes, human papilloma virus, HIV, AIDS, chlamydia, and syphilis. For pregnant women with an STD may infect their baby before, during, or after the baby's birth. For this reason, Your healthcare provider will screen you for most STDs at your first prenatal visit. If you have sex with someone who is affected after your initial screening, you will need to be tested again. Treatment of STDs is the best way to protect you and your baby. Next is we have the objectives of care. So after 1 week of holistic nursing care, the client will be able to manage and identify ways to alleviate pain. We have here for the specific objectives. After 3 days of nursing intervention, the client will be able to report pain is relieved or controlled, demonstrate use of relaxation skills and diversional activities, verbalize sense of control, of response to situation, and positive outlook for the future. So here are our nursing interventions. We have independent. For the independent nursing intervention, perform comprehensive assessment of pain, note the location intensity, the duration, the frequency, and the onset. Second, instruct client to report pain as it develops rather than waiting for it to be severe. Third, encourage client to verbalize their feelings. Fourth, provide non-pharmacological methods of pain management like deep breathing exercises and meditation. So for our dependent nursing intervention, first is to administer analgesics and or antipyretics as ordered. Second is evaluate the effectiveness of the medication as ordered and observe for any signs and symptoms.
Hello, good day. I am Cassandra Maureen VILLANEUVA, and I will now be discussing the TORCH infection. But before anything else, what is the definition of TORCH? So, it is an infection of a developing fetus or newborn that can occur before birth, during delivery, or after birth. It can be caused by any of the group of infectious agents indicated in the acronym TORCH, which stands for T for Toxoplasma gondii, O for other agents such as Treponema pallidum, varicella zoster virus or VZV, parvovirus B19, and human immunodeficiency virus or your HIV. R stands for rubella, C stands for cytomegalovirus or CMV, and H stands for herpes simplex virus or HSV. So it is caused by an in utero infection with one of the TORCH agents disrupting fetal development. A baby contracts a TORCH infection in the uterus when the mother catches the infectious disease and carries it through her bloodstream to the baby. Infections in this category may be caused by various viruses. Other organisms such as bacteria, spirochetes, protozoa, or yeast also may cause maternal infections which are harmful to the developing fetus. Infection organism may also be acquired through the following. We have first sexual intercourse, second is human body fluids such as semen, saliva, blood, urine, cervical mucus, breast milk, and even stool. Third is eating undercooked meat, and lastly, by contact with infected cat feces in the litter box. So now we move on to the different types. So first we have toxoplasmosis. It is a parasitic illness caused by the microscopic parasite Toxoplasma gondii. This one-celled parasite is most prevalent in cats, but it may also infect people and other animals. Second is we have other agents such as Treponema pallidum, VZV, parvovirus B19, and HIV. It is a bacterial infection that usually spreads by sexual contact. Next is rubella. It is a contagious viral infection. It is best known by its distinctive red rash. So, rubella can cause serious problems for unborn babies whose mothers became infected during pregnancy. We also have cytomegalovirus or the CMV. It is a common virus. Remember that once infected, your body retains the virus for life. It has a wide range of symptoms, from no symptoms to fever and then fatigue. Lastly, we have herpes simplex virus or the HSV. It is a viral infection that causes genital and oral herpes.
For the signs and symptoms of torch infection, we have here cataracts. Cataracts are the clouding of the lens of the eye, which is normally clear. Most cataracts develop slowly over time, causing symptoms such as blurry vision. Next is jaundice. Jaundice is a yellow color seen in the skin of many newborns. Jaundice happens when a chemical called bilirubin builds up in the baby's blood. Reddish brown spots on skin. Also, we have hepatosplenomegaly or HPM. This is a disorder where both the liver and spleen swell beyond their normal size due to one of a number of causes. Also, congenital heart disease. This is a general term for a range of birth defects that affect the normal way the heart works. The term congenital means the condition is present from birth. Next is microcephaly. Microcephaly is a condition where a baby's head is much smaller than expected. Also, low birth weight, hearing loss, fever, lethargy, blueberry muffin rush. Next is for nursing management. First is we're going to be assessing for any previous history of sexually transmitted diseases, also demonstrate proper hand washing techniques, and lastly discuss hygienic and dietary measures that will help reduce the risk of infection. For medical management, treatment is highly dependent on a specific agent responsible for the infection. A torch screen is a panel of tests for detecting infections in pregnant women. Infections may be passed on to a fetus during pregnancy. Early detection and treatment of an infection can prevent complications in newborns. The test screens for antibodies to infectious diseases. Antibodies are proteins that recognize and destroy harmful substances such as viruses and bacteria. Pharmacologic management. Most healthy people don't require toxoplasmosis treatment. But if you're otherwise healthy and have your signs and symptoms of acute toxoplasmosis, your doctor may prescribe the following drugs. First is pyrimethamine or darafrim. This medication, typically used for malaria, is a folic acid antagonist. It may prevent your body from absorbing the B vitamin folate, folic acid, vitamin B9, especially when you take high doses over a long period. For that reason, your doctor may recommend taking additional folic acid. Other potential side effects of pyrimethamine include bone marrow suppression and liver toxicity. Next is sulfadiazine. This antibiotic is used with pyrimethamine to help treat toxoplasmosis. For surgical management, first is routine universal screening should not be performed for pregnant women at low risk. Next, serologic screening should be offered only to pregnant women considered to be at risk for primary Toxoplasma gondii infection. Next is suspected recent infection in pregnant women should be confirmed before intervention by having samples tested at Toxoplasmosis Reference Laboratory. Also, amniocentesis should be offered to identify Toxoplasma gondii in the amniotic fluid by polymerase chain reaction. Next is amniocentesis should not be offered for the identification of Toxoplasma gondii infection at less than 18 weeks gestations and should be offered no less than 4 weeks after suspected acute maternal infection to lower the occurrence of false negative results. Lastly, Toxoplasma Toxoplasma gondii infection should be suspected and screening should be offered to pregnant women with ultrasound finding consistent with possible TORRED infection, including but not limited to intracranial calcification, microcephaly, hydrocephalus ascites, hepatosplenomegaly, or severe intrauterine growth restriction. Next is for relevant pictures and videos. We have here the meaning of torches, toxoplasmosis, rubella, CMV, herpes, enterovirus, syphilis. And we also have here a YouTube video that explains TORRED infections.
Hello, I am Cassandra Maureen VILLANEUVA, and I will be discussing the objectives of care. So, we have here the general objective. After 3 days of holistic nursing care, the client will be able to regain normal body temperature. For these specific objectives, after 8 hours of nursing interventions, the client will One, regain a body temperature below 39 degrees Celsius. Second, maintain normal blood pressure and heart rate. For the nursing interventions, measures to help the client normalize her temperature. So, first, monitor the patient's heart rate and blood pressure. For the rationale, this is done to have data to compare when assessing whether the interventions are effective on the client. These vital signs are specifically important to take note of, as in hyperthermia, both the heart rate and the blood pressure increase. Second, monitor fluid intake and urine output. Fluids, especially cool fluids, are a way to lower the body temperature. Furthermore, monitoring both intake and output of the fluids is important, as dehydration is a factor in hyperthermia and should be treated appropriately. Third, evaluate the effects or degree of hyperthermia. This is done to give the appropriate interventions um, depending on the symptoms of the degree of the client's hyperthermia. Fourth, promote surface cooling by means of undressing and application of tepid sponge bath. Undressing reduces heat and promotes evaporative cooling. Tepid sponge bath is also another way of promoting evaporative cooling, which aids in lowering the client's temperature. Fifth is administer antipyretics as prescribed by the physician. So, the use of antipyretics is a pharmacologic way of lowering the client's body temperature.
Good day everyone, I am Yvonne and today I will be talking about multiple pregnancy. What is multiple pregnancy? Multiple pregnancy is a pregnancy with two or more fetuses. So naturally, twins occur in about 1 in 250 pregnancies, triplets in about 1 in 10,000 pregnancies, and quadruplets in about 1 in 700,000 pregnancies. So, as the number of fetuses increases, this means to say that the expected duration of pregnancy also decreases. So, an example is the average duration for the twins is only about 35 weeks, and then 33 weeks for triplets, and 30 weeks for quadruplets. Now, what is its cause or its etiology? So, multiple pregnancy occurs when more than one egg is fertilized. It can also happen when one egg is fertilized and subsequently divides into two or more embryos, each of which develops into two or more newborns. So when one fertilized eggs divides into two, this means that we can have identical twins, or the newborns are also known as identical twins. Now, for the types of multiple pregnancy, we have the twins and triplets, or the higher order multiples, the HOM. So, first we have the fraternal twins, also called as dizygotic twins. It is formed when two separate eggs are fertilized and implanted in the uterus. So the twins may look similar or different and may differ or have the same sex. Second is what we call identical twins. So this is also referred to as monozygotic twins. It is formed when a single fertilized egg is split in half, wherein both halves embryos are genetically identical, so are alike, and the babies will share many characteristics. Then we have the triplets and the higher order multiple, the HOMS. HOMS. This is referred to as trizygotic um, triplets. So triples, quadruplets, and many more can be a different combination of the two previous types of multiple pregnancy. We have the fraternal and the identical. Now, for the signs and symptoms, each woman may have slightly different symptoms, but most common symptoms of multiple pregnancies are: first, uterus is larger than expected for the dates in pregnancy; second, more morning weakness, and then greater appetite. Next one is too much weight gain, especially in early pregnancy, and baby's movement felt in different parts of the stomach at the same time. Now let's move on to the management. For the nursing management, assess the mother's nutrition. Mothers carrying two or more fetuses need more calories, protein, and other nutrients, including iron. And then higher weight gain is also recommended for multiple pregnancies. The mother's nutritional status and weight should also be monitored more closely. Then, we encourage mothers to increase rest. So, higher order multiple pregnancies often requires bed rest starting in the middle of the second semester, or second trimester rather. I apologize for my mistake. And then we have the medical management. First is maternal and fetal testing. Testing may be needed to monitor the health of the fetuses, especially if there are pregnancy complications. And then we have the referrals. Referral to a maternal fetal medicine specialist, also called as perinatologist, for special testing of ultrasound evaluations and to coordinate care of complications may be also necessary.
Hello everyone, this is Roby YBANEZ. I'll be discussing pharmacologic management of multiple pregnancy. So, tocolytic medications may be given if preterm labor occurs to help slow or stop contractions of the uterus. This may be given orally in an injection or intravenously. Tocolytic medications often used include magnesium sulfate. Also, corticosteroid medications. Corticosteroid medications may be given to help mature the lungs of the fetuses. Lung immaturity is a major problem of premature babies.
Hello, my name is AINHOA ZALDUMBIDE and I'll be continuing the discussion for the different categories of management of multiple pregnancies. And lastly, we here have surgical. And for this, we have the cesarean delivery. Cesarean delivery is default in twins when the first fetus to be delivered is not in vertex position. However, if only the second fetus is not vertex, then the first one is delivered through normal vaginal delivery, also known as NVD. And the second one has to be rotated or an emergency cesarean may be done. Without any of the mentioned conditions and any other complications, twins can be delivered NVD. For 3 or more pregnancies, a planned cesarean delivery is used or highly recommended due to the number of risk factors when delivering 3 or more babies vaginally. Moreover, some of these risk factors are due to the position of the fetuses and their placentas. During an NVD, the umbilical cord can be compressed and there is a much higher risk of entanglement. The next slide here, we have some relevant pictures, and the picture on the left depicts different situations with twins in regards to their amniotic sac and their placenta. So here in the left picture, in the upper left, we have a monoamniotic and monochorionic. So that means that they share the same amniotic sac and they have the same placenta. On the bottom left, this is diamniotic and monochorionic. So that means that they have a separate amniotic sac, but they share the same placenta. And on the right, they are both diamniotic and dichorionic. The only difference is the one on the upper right is fused, and the one in the bottom right is separated. Next, we have the next picture. We have identical twins and fraternal twins. So for the identical twins, it is one egg, one sperm, and they share the same placenta, but they have separate amniotic sacs. So this is diamniotic monochorionic. And here we have fraternal twins, which is 2 eggs, 2 sperms, and they have separate placentas and also separate amniotic sacs. So they are diamniotic and dichorionic. On the next slide, we have a relevant video that talks about the identical twins and the fraternal twins more in depth. So please go and watch this.
So excited that you're here with me today. We're going to talk about genetics, but specifically about twins. And twins are really fascinating, and most people are fascinated and want to talk to parents of twins about their twins. So they approach them with sometimes very interesting questions, but sometimes ill-informed questions. So my goal is to educate you so the next time you talk to a parent of twins, you can impress them with your knowledge. So we're going to talk about the difference between identical and fraternal twins. And with identical twins, they're called monozygotic. So monozygotic, mono meaning one, means that one zygote is formed. With fraternal twins are dizygotic, di means two, so two individual zygotes are formed. So let's look at how that happens. So this is the egg here, and this is our sperm, and you can see the sperm is very small compared to our large egg. And if we were to look in the microscope, you would see that a human egg is very, very large, and a human sperm is very, very tiny. That's because the egg carries all that good information, and what the sperm brings is the genetic information, which is all it needs to bring. So with your monozygotic twins, what happens is one sperm fertilizes this one egg. Now in a normal situation, this would then go down into the uterus, and then we would have gestation for about 9 months, and then a baby would be born. That's how most individuals are born, one at a time. But in this case, the special case of monozygotic twins or identical twins, this one zygote then splits into two individuals. So now we have two genetically completely the same individuals. These are essentially clones genetically of each other. They both travel down into the uterus and gestate for about 9 months, and you're born with two individuals that are going to be boy-boy or girl-girl. You can never have a boy-girl set of identical twins because they have to have the same genes, the XX for girls and the XY for boys. So these are your identical twins. With identical twins, these are pretty rare. There's actually no known cause. Scientists aren't sure why this happens. It's just an extra set of cell divisions that happens. And it's about 1 in every 250 births that this happens. So it's just a random chance that this will happen anytime there's a fertilization event. So no reason for that. But when we look at fraternal twins, again, dizygotic, so two zygotes or two eggs are going to be ovulated at the same time from the mother, and that is unusual. Usually it's only one at a time. So in this case, we have two eggs from a hyper-ovulating mother, and then we have two sperm from the father. So you can see that they're different colors because they're different genetically. So these individuals have their own genes. They are not clones of each other. They're actually no more related than normal siblings who are born years apart. So these are your dizygotic twins. So these can be, again, boy-boy, they could be girl-girl, or they could be girl-boy because they are unique genetically. The odds of this are going up dramatically. So since the 1980s, the amount of multiples, not just twins, but triplets and quadruplets have gone up due to all the fertility treatments that people are undergoing. But actually, twins without fertility treatments occurs for multiple reasons. So there are certain populations that have higher incidences of fraternal twins. So older mothers are more likely to have fraternal twins. Populations from Africa are more likely to have fraternal twins as well. And the mother who is going to have fraternal twins is called a hyper-ovulating mother, and she inherits that. That is a genetic thing. So there are specific genes now that we know you can pass on in the maternal line to that mother to allow her to ovulate more than one egg at a time. So it is something that you inherit, and that's what the mother inherits. It has nothing to do with the father specifically. So the mother has to ovulate those two eggs at the same time. So again, when we look at this, this is your dizygotic twins, so those are fraternal twins. These are your identical twins, and again, those are monozygotes. So the next time you see some twins with their parents out and about, you can come up to the parents and say, number one, you're doing an amazing job because you have a very hard situation with multiple kids at the same time, so you're amazing, right? But also then you can impress them with your knowledge. You can say, hey, if you have a girl-girl or a boy-boy, you can say, are they monozygotic? And they'll say, what? And you'll say, identical, are they identical? And they'll say yes or no based on whether or not they know that. Now, the only way you can tell that is by doing a DNA test, which can easily be done. If you see twins that are boy-girl, you can automatically know that they are dizygotic, and you can tell their parents, hey, your dizygotic twins are adorable, right? So twins, they're amazing, fun to talk about with genetics, and definitely not scary.
Next, we have here the nursing care plan for multiple pregnancy. So let's start with the needs, problems, and cues. So our physiological problem is fatigue. So some objective cues for this is pale or yellowish skin, rapid heartbeat, shortness of breath. Next, we have subjective cues. So the client verbalized, kapoy kayo akong lawas, permi, unya, sige sad kog kalipong, usahay maglabad sa akong ulo. So the diagnosis for this is fatigue related to increased physiological demand of a multifetal pregnancy. And the scientific basis for this is that extreme fatigue is the most commonly reported complaint by mothers with multiple pregnancies. During the first trimester, sleepiness, lethargy, and exhaustion is increased because of the body is working overtime to nurture more than one baby. So the objective of cares for this, after 4 hours of holistic nursing care, the client will be able to feel relieved and well rested. Specific objectives, after 2 hours of nursing intervention, the client will, number 1, have a normal heart rate and respiration. Number 2, have a better activity and rest schedule. Number 3, understand the underlying cause of fatigue. Now for the nursing intervention and the rationale. So here are some measures to gain adequate rest and sleep. Firstly, evaluate the client's description of fatigue, severity, and its changes over time, aggravating factors or alleviating factors. So using an appropriate quantitative scoring scale, such as 1 to 10, might help the patient formulate the amount of exhaustion experienced using graphics or descriptive text. Additionally, scoring scales can be created. This system allows the nurse to compare changes in the patient's fatigue level over time. It is critical to determine whether the patient's level of weariness is consistent or varies over time. The second nursing intervention is observe the client's physiological reaction to activities such as any alterations in BP, respiratory rate, or heart rate. This is done to determine the physical responses related to both physiological and emotional conditions. The third intervention is educate the client and family about the underlying causes and effects of fatigue, as well as non-pharmacological techniques to promote rest. This is to give awareness to the client as well as to the family about the condition. On the other hand, non-pharmacological techniques is very helpful to the client to easily alleviate fatigue. The fourth intervention is aid the client in developing a schedule for daily activity and rest. This is done because a schedule that alternates between periods of activity and periods of rest can help the patient perform desired activities while reducing fatigue levels. The fifth intervention is administer medication as prescribed by a physician. This is because taking your prescription as directed, often known as medication adherence, is critical for controlling chronic disorders, treating acute conditions, and overall long-term health and well-being. The sixth intervention is teach energy conservation methods and collaborate with a occupational therapist if needed. This is to use available energy to perform desired activities. Patients and caregivers may need to develop skills such as task delegation, prioritization, and cluster care. Organization and time management can assist the patient in conserving energy and decreasing weariness. The occupational therapist can provide assistive gadgets to the patient as well as educate the patient on energy conservation techniques. And that was the last slide for the multiple pregnancies. And I will now lead you to the reporters for Hydramnios.
Hello, good day everyone. I am Maria JHORIZA UBAS and today I will be discussing Hydramnios. Along with me is Miss Henrelyn VILLAMOR and Miss Roby VILLACERAN. So to start off, let's first define what is Hydramnios. So Hydramnios is a condition in which the amount of the amniotic fluid is more than 2000 ml relatively to the age of gestation. It happens in about 1% of pregnancies. However, to make the diagnosis more accurate and practical in clinical settings, in ultrasonography, Hydramnios has a single deepest pocket, equal or greater than 8 centimeters, and an amniotic fluid index, equal or greater than 25 centimeters. So for the etiology and causes, the amount of fluid increases until the 36th week of pregnancy. After that, it slowly decreases. If the uterus makes too much urine or does not swallow enough, amniotic fluid builds up. This causes Hydramnios. Other causes are related to an underlying diseases such as fetal malformations and genetic anomalies, maternal diabetes mellitus, multiple pregnancies, fetal anemia, other causes, example given, viral infections, Bartter syndrome, neuromuscular disorders, maternal hypercalcemia. Viral infections which can lead to polyhydramnios include parvovirus B19, rubella, and cytomegalovirus. Other infections, example given, toxoplasmosis and syphilis, can also cause polyhydramnios 80, 81, 82. So for the types of hydramnios, first is the mild hydramnios. So mild hydramnios may not cause any problems. Often, extra fluid that appears during the second trimester returns to normal on its own. Mild hydramnios is more common than severe hydramnios. On the other hand, with moderate hydramnios, the extra fluid may make it more difficult for you to feel your baby moving. You may also be uncomfortable and breathe less because of the extra fluid pressing against your lungs and other parts. Lastly, for severe hydramnios may mean there is a problem with the fetus, birth defects of the brain and the spinal column, blockages in the digestive system, a genetic problem, a problem with the chromosomes that is inherited. Next is for signs and symptoms. Fast growth of your uterus, in which some may exhibit an overly enlarged uterus accompanied with some difficulty in feeling the baby during prenatal checkups. Stomach discomfort, uterus that is larger than normal for how far along you are in pregnancy, labor pains, which is contractions, dyspnea, heartburn, fetal malposition, uterine discomfort, and lastly, abdominal pain. So for the management, nursing advise the patient to take bed rest to increase uteroplacental circulation and reduce the pressure on the cervix. Second, help the woman avoid constipation, as straining could increase uterine pressure and cause rupture of the membranes. Lastly, assess the woman's vital signs and lower extremities edema frequently. Next is for medical. First is blood test. Blood tests for infectious diseases associated with polyhydramnios may be offered. Second, non-stress test. This test checks how your baby's heart rate reacts when your baby moves. During the test, you will wear a special device on your abdomen to measure the baby's heart rate. You may be asked to eat or drink something to make the baby active. A buzzer-like device also may be used to wake the baby and encourage movement. Lastly, the biophysical profile. This test uses an ultrasound to provide more information about your baby's breathing, tone, and movement, as well as the volume of amniotic fluid in your uterus. It may be combined with a non-stress test. For the pharmacologic, there is prostaglandin synthase inhibitor. This stimulates fetal secretion of arginine vasopressin, which results to vasopressin-induced antidiuresis, which reduces renal blood flow that results to reduced urine output. Moreover, this also inhibits fetal lung liquid production or can increase the reabsorption. This medication is used in the first and second trimester of pregnancy, and patients are advised not to take this medication after the 20th day of gestation. On the other hand, Solendac and indomethacin, these are the non-steroidal anti-inflammatory drugs and are used to reduce amniotic fluid volume. Lastly is surgical. Amniocentesis may be used by the doctor to remove extra amniotic fluid from your uterus. This technique has a low risk of complication, such as preterm labor, placental abruption, and premature membrane rupture.
Hello, good day. I'm Henrelyn A. VILLAMOR, and I'll be continuing the report about the topic Hydramnios. So we have here relevant pictures and video. On the right side is a picture of what a pregnant woman with polyhydramnios would look like. On the left, a procedure called amniocentesis is shown, wherein a needle is inserted through the uterus and into the amniotic sac, which can help drain the excess amniotic fluid. So to further understand the topic, we have here a video.
Let's talk about oligohydramnios and polyhydramnios and everything you need to know about them for your boards and clerkships. But first, let's take a step back and look at how these states are defined. Oligohydramnios is when there is a decreased amount of amniotic fluid, which is what those down arrows are highlighting. And polyhydramnios is where there is an increased amount of amniotic fluid, which is what the up arrows are highlighting. But to be more precise in the definition of oligohydramnios and polyhydramnios, we use the amniotic fluid index to define them. So normal amniotic fluid is between 5 to 24 centimeters. So amniotic fluid less than 5 is oligohydramnios, and amniotic fluid greater than 24 is polyhydramnios. So now you know the numbers, but you might be wondering what influences the amount of amniotic fluid that is present. Well, simply put, it's influenced by 3 main things. 1. Swallowing. 2. Placental insufficiency. And 3. Urinating. Swallowing causes the amniotic fluid to leave the amniotic sac and enters the fetus, so swallowing decreases the amniotic fluid. However, urinating does the opposite. Urinating adds to the amniotic fluid. Some people even say the amniotic fluid is basically just a sack of the baby's pee. So more urination equals more amniotic fluid. And now we have the placenta. So the placenta transfers nutrients from the mother to the baby, and it allows the baby to receive everything it needs for adequate growth and development. So if the placenta is affected, this affects growth and development, which in turn decreases the amniotic fluid production. So placental insufficiency decreases amniotic fluid. Overall, swallowing decreases amniotic fluid. Placental insufficiency also decreases amniotic fluid, and urination increases amniotic fluid. Now that we understand those basic concepts, let's look at oligohydramnios. So using the amniotic fluid index, oligohydramnios is defined as a state where there is less than 5% of amniotic fluid. So there is less amniotic fluid than what is normal. A contributor to the development of oligohydramnios is placental insufficiency. This occurs in any state that affects the integrity of the placenta. This includes hypertension or preeclampsia, diabetes mellitus, and sickle cell disease in the mother, and of course, abruptio placentae. So remember, placental insufficiency causes a decrease of amniotic fluid. Another factor that contributes to the development of oligohydramnios is urination. Well, more specifically, if urination is affected, this causes oligohydramnios. This can be due to states like renal agenesis or posterior urethral valves. Another important factor are drugs used by the mother, such as NSAIDs, ACE inhibitors, and ARBs, because they can lead to renal insufficiency or affect the overall development of kidneys. So overall, oligohydramnios is caused by placental insufficiency and any state that causes a decrease in urination. An extremely high-yield association with oligohydramnios is pulmonary hypoplasia. So let's try to understand the pathophysiology behind this. A normal amount of amniotic fluid allows for a normal amount to enter the lungs. Thus, there is a normal volume of liquid in the lungs. This normal volume of liquid in the lungs causes an adequate expansion of the lungs, leading to overall a normal lung development. So normal amount of fluid equals to a normal lung development. However, in oligohydramnios, the amniotic fluid is decreased, thus affecting the overall growth and development of the lungs, causing pulmonary hypoplasia. Knowing the association between oligohydramnios and pulmonary hypoplasia is very, very high yield, so never forget it. Another high yield association is the connection between pulmonary hypoplasia to Potter sequence. So Potter sequence arises due to renal agenesis, which is labeled as number 1 right here, because it is the inciting or initial event. Recall that renal agenesis causes decreased urination, and so it is a cause of oligohydramnios, which is labeled as number 2. This then leads to pulmonary hypoplasia, as we discussed before. The other features of Potter sequence include twisted face, twisted skin, and extremity deformities. So these features are seen because amniotic fluid acts as a kind of cushion for the baby from injury or trauma. So when there's too little of this, the protective effects of amniotic fluid are taken away or very limited. My question for you is what tocolytic can cause oligohydramnios? Leave the answer down below in the comment section. And if you are enjoying this high-yield content so far, be sure to power up the like button, hit subscribe, and that notification bell. Now let's continue. We have to know the complications of oligohydramnios, and these include fetal malposition, umbilical cord compression, preterm delivery, and meconium aspiration. So it's very important that you realize that if there is too much or too little amniotic fluid, this can lead to fetal malposition. And speaking of too much amniotic fluid, let's talk about polyhydramnios. So, as defined by the amniotic fluid index, polyhydramnios is a state where the amniotic fluid is greater than 24 centimeters. A major contributing factor to polyhydramnios is swallowing. So, if swallowing is decreased, that means that more amniotic fluid can be in the amniotic sac. The causes of decreased swallowing include the most common, which is idiopathic, as well as anencephaly, esophageal or duodenal atresia, and tracheoesophageal fistula. So these are all states that affect swallowing. And the next factor that contributes to polyhydramnios is urination, specifically increased urination. So this includes multiple gestation. So 2 babies equals double the P, so that's more P. And maternal diabetes mellitus. This is because the hyperglycemic state triggers an osmotic diuresis in the fetus, so they produce even more urine. So essentially, the main contributing factors to polyhydramnios are decreased swallowing and increased urination. Complications of polyhydramnios include fetal malposition, umbilical cord prolapse, preterm labor, PPROM, and postpartum hemorrhage. So recall that the most common cause of postpartum hemorrhage is uterine atony. And uterine atony can occur due to uterine distension. And of course, polyhydramnios is a cause of uterine distension. So that's why polyhydramnios can cause postpartum hemorrhage. Also, if you look at the first 2 complications here, you can see that they were also listed as complications for oligohydramnios. So remember that fetal malposition and umbilical cord prolapse are complications of both oligohydramnios and polyhydramnios. So you know that the most common cause of polyhydramnios is idiopathic. But what is the most common cause of oligohydramnios? And the answer is rupture of membranes. So in summary, oligohydramnios and polyhydramnios are both states where there is an abnormal amount of amniotic fluid. Using the amniotic fluid index, oligohydramnios where there is less than 5 centimeters of amniotic fluid, while polyhydramnios is where there is more than 24 centimeters of amniotic fluid. The most common cause of oligohydramnios is rupture of membranes, while in polyhydramnios the most common cause is idiopathic. Causes of oligohydramnios include placental insufficiency. So this includes states like hypertension, preeclampsia, diabetes mellitus, or sickle cell disease, as well as decreased urination. This occurs if the fetus has posterior urethral valves or renal agenesis, or if the mother is taking drugs that affect the development of the fetus, such as NSAIDs, ACE inhibitors, and ARBs. While for polyhydramnios, it's caused by decreased swallowing. That includes states like anencephaly and TE fistulas. And diabetes mellitus and fetal hyperglycemia are states that trigger a osmotic diuresis in the fetus, causing increased urination. The main contributing factors to oligohydramnios include placental insufficiency and decreased urination. While for polyhydramnios, that includes decreased swallowing and increased urination. The very high yield association that we must remember for oligohydramnios is pulmonary hypoplasia, which is a part of the Potter sequence. And that brings us to the end of this video. If you like this content, be sure to power up the like button, hit subscribe, and that notification bell. As always, thank you so much for watching, and to continue learning more, click this video right here. Thank you, bye!
Now for the nursing care plan. For the needs, problems, and cues, we have physiological problem, acute pain. The objective cues are sweating, shows facial grimace, and restlessness. The subjective cues are the client verbalized that she is experiencing cramping in her abdomen and back. The client rates the pain intensity 7 out of 10. The nursing diagnosis is acute pain related to increased uterine pressure as evidenced by pain rate of 7 out of 10. For the scientific basis, as pregnancy progresses, the uterus stretches and the pelvic floor weakens to accommodate the growing baby. This pressure can cause a feeling of fullness in the vagina are generalized pain and pressure in the hips, abdomen, and pelvis.
Hi, I'm Roby VILLACERAN, and I'll be talking about the objectives of care, the nursing interventions, and the rationale. So, for the general objectives, after 8 hours of holistic nursing care, the client will be able to report that she feels comfortable and better. For the specific objectives, after 3 hours of nursing intervention, the client will, number 1, provide a pain intensity of 4 or lower. Number 2, understand the risks and underlying causes of the acute pain. And 3, display a better behavior and or mood. For the nursing interventions, we have here the independent nursing interventions. Number 1, obtain consent from the patient to perform amniocentesis as ordered after explaining the procedure's purpose, benefits, and risks. So severe cases may require the drainage of excess amniotic fluid through amniocentesis. This procedure will help reduce the pressure in the uterine and abdominal walls, thus alleviating the pain. Next, conduct a comprehensive assessment of pain using cold spa. So using cold spa will help improve the nurse's understanding of the patient's concerns. This allows the nurse to create a customized nursing care plan that effectively addresses the patient's need for comfort. Number 3, place the mother on close monitoring. So pregnant women with mild hydramnios will be closely monitored for any worsening signs or symptoms. Fourth, assess the patient's vital signs. So this is to monitor the effectiveness of the medical treatment for the pain of relief. So next, we have here the dependent nursing interventions. First, administer medications prescribed for the management of amniotic fluid volume. The physician may prescribe medication to facilitate the reduction of the amniotic fluid volume. Next, administer medications as ordered for pain. So this is to alleviate abdominal pain. That would be all for our report. In the next slide, we have here our references. Thank you and God bless.